Okay, today I wanted to go through the waveform lab that we went through on Monday the 25th. So I'm going to run through this sheet and kind of do a little demo here on the 980 ventilator. It's our newest ventilator that we just purchased from Covidien. So first thing I'm going to do is set the ventilator to the volume assist control and discuss the three scalars. So I do have this in assist control, volume control, with a patient's ideal body weight at 65 kilos. So you can set that up when you are working on this ventilator. So let's go to, we'll start from ARDSnet and go to 8 mils per kilo. Notice when I'm doing that, of course, if I'm at the NBRC hospital, I'll have to get out my calculator. But on this one, I can actually put in my tidal volume, and it'll give me how many mils per kilo is actually working. So other things I want to set are my rate. So let's start at 8 mils per kilo, rate of 12. Here we have a peak flow. We have a our decelerating waveform, which we'll use, our sensitivity or our trigger, and this one's a flow sensor trigger, and that's something you could choose between pressure or flow. And we're going to go at 3 liters per minute, room air, just because that's what we have here in the lab, and then we're going to start at a peak of 5. So when we talk about our three scalars, we're talking about one variable versus time. So the first one here is pressure. And so this is our pressure versus time waveform here. And I'm just learning. Oops. Here you can do that with your finger. So you can get the scale so you can see it a little bit easier. So we'll go there. That looks pretty good. Okay, so pressure versus time, flow versus time, tidal volume versus time. So we are in assist control, volume control, where of course we are setting a peak flow. Okay, so we know that we're in volume control. So we're looking at our different waveforms. Right here, we see that we are in a decelerating. So generally, when you're in volume control, you're in a constant square waveform. That looks like this. So you'll notice here that there's a constant square. That's usually typical of a volume control, but this ventilator's really nice, and so it allows you to have a decelerating as well. Okay, so we can see that we're in a 1:4 IDE set, IDE ratio. Our PEEP's at 5, 8 mils per kilo. Okay, so nothing too interesting on our waveforms. Here we have a pressure, a consistent pressure. Now this will change because I have a set tidal volume and a set inspiratory flow. So as my dynamics, my pulmonary mechanics change, that will change my peak pressure. Okay, but we have a consistent tidal volume here. Now another thing we can do on this ventilator is look at our loops as well. So here, there's a variety of things. We can have all 5, so let's choose layout 4. Okay, so now we have in addition to our 3 scalars, we have our 2 loops. We have our pressure volume loop, and then we have our flow volume loop. Now remember, when we do PFTs, we're used to looking at this flow volume loop inverted because we're more focused on the expiratory flows, where here we're looking at the entire breath cycle. And in here, we are looking at our, our pressure volume loop, and this is a great one to look at. So once again, the things that you can really identify with the loop are your lower and upper inflection points. You can see if you're getting any over distension, as well as you can look at the compliance of the patient's lungs. So if we took, I'll do a couple of things here. We'll try and, oops, try and get the, there we go. There we go. That might help us see this just a little bit better. And if you took the slope here, and the slope is, you know, the rise over the run. So if you drew a line between, and I can kind of use my paper here, the beginning and the end. If you just look at that slope or the shape of that, this is these lungs right here are very compliant. Okay, they're very compliant. So one other thing about the pressure volume loop is that it goes in a counterclockwise direction during a ventilated breath. So it starts here and goes here. So inspiratory is here and in green, and the yellow portion is our exhalation. Okay, let's adjust our flow so we can get a little bit shorter. We'll start out at 60 and see if that makes any difference here. Okay, let's give it a minute, maybe a little bit. You can kind of see that our inspiratory time was a little long previously, so we're trying to smooth that out just a little bit. As I said, we have very compliant lungs, so they will easily accept a lot of peak flow and volume right away. Okay, so doesn't change as we haven't changed the pulmonary mechanics. It's not going to change the slope pattern, but we'll see if we can get it a little bit smoother. We want it to look more like a football. So as you can see, with our peak pressure is only 15, we have very compliant lungs. If we want to do a respiratory maneuver here, we can get both our plateau pressure and our static compliance. So our plateau pressure is only 9.9. So as we said, our static compliance is 113 mils per centimeter. So like 100 is absolutely perfect. So these compliance are, or excuse me, these lungs are like a little bit overly compliant. So okay, easy to ventilate. Okay, so one of the things I want to do now is to go into the different modes. So now I am going to go back and go to a pressure control mode. Okay, so we didn't need much here. So now rather than a volume, we're still going to target that volume that we were at before, which was 520 was 8 mils per kilo. So now our inspiratory pressure is going to be about 15, and that's about what we were before. So here we can do our inspiratory time. Once again, very compliant lungs. We might not need that much. Let's see, rate of 12. Sensitivity, once again, stays at 3. Our peak's at 5. Now here is something extremely important, guys. We can't ever forget, and that is what our high peak is. So especially with these very compliant lungs, we don't want a patient to have to, you know, cough and go over a certain peak pressure. So this is a control variable that will stop the breath, and if it gets over this pressure, then we will not be giving any more volume. So I'm gonna, since we're only at about 15, I want to know if my lungs are compliant or not, and if the compliance is changing. So I'm going to go ahead and set that tight, MBRC tight. So 10 centimeters of water pressure over what I've got set here. So if I have it set at 15, now when I change this over, it's going to be 15 over the baseline of 5. I do have the peak level set at 5, so the high peak then, the peak inspiratory pressure will be 20. So I'm going to go ahead and set this to 30, so 10 above that. Okay, so we're going to go ahead and accept this. Okay, we're still monitoring. Oh boy, we got 1,031. So we need to definitely get these, get the peak inspiratory pressure down, because our tidal volume that we were getting was very high. So closer to about 15 mils per kilo. So we don't want to do that. Okay, we're still getting about 807, so that's still too high. So once again, very compliant lungs. So 7/5. We'll see a peak of 12. Excuse me, I'm sorry. Yeah, our peak of 12. Okay, now look at this curve. If you notice, that looks fantastic. We still have the really compliant lungs due to the fact that we haven't changed anything. So those are still overly compliant. Now let's look at our scalars. So our scalars, here's our pressure, and once again we'll change the scale, okay, because they're compliant lungs, we're not going too high here. Now once again, pressure, flow, volume. Now if we did change our mechanics a little bit, or had any spontaneous or whatnot, our volume is what's changing. And you can see that one was smaller than what we'd gotten before. Okay, so it's this one, the volume that's going to change. Pressure is going to stay consistent. And now flow right here will change to allow the different, as the mechanics changes, the volume will change as we're in pressure control. Now, one of the things that is pretty cool about this, now we can control our inspiratory time. Notice our flow goes away, and now our rise time can change. Okay, so we can change that. So I'm going to change our layout here. So we're going to go to layout 2, where we see our pressure and our flow. You know, one of the things we all have to do or learn on different, oops, here, got a little bit lower there, learn on different ventilators. So rise time can be called different things, but here it's the percentage of inspiratory time that's going to get to the peak pressure, either faster or slower. So right now we're kind of in the middle. Now this is really sensitive, as we can go all the way down to 0. Okay, so let's try that. Okay, or we can go to 1. So we'll go to 1. Now watch our values here, or watch our curves. Everything looked pretty good. Okay, we got that breath in, and everything looked pretty good, because once again we have these really compliant lungs. So this is the rise time of 1% versus, let's go all the way to the opposite end of 100%. Okay, you can see a little bit of a spike here at the end, at the very beginning. There we go. That might work. Now these lungs, as I said, so compliant, you can do about anything on here. So one of the things you do see is a very small blip right here, and I can even pause this. I'm learning all this new stuff on this vent, so I can pause this, and I can bring this cursor, so really highlight that there is a little blip right there, and that's because this breath goes in so fast. The minute it starts delivering, it gets to peak pressure. So here, we'll take that away. So we'll continue on. That just paused it. Now we'll go back to real time again. So we'll let this catch up. And as I said, you can see a little bit of peak here. So we will go down some. Let's try 75% rise time and see how our waveforms look here. There we go. Okay, that looks great. So very compliant lungs means I can get the breath fast, so you can have a much faster rise time if need be. And so that little blip disappeared as we turned the rise time down. And we're smooth breathing again. And you can see that via your waveforms. Okay, this patient is not triggering at all. We're still in, pressure control, assist control. One of the things I want to do now is show you the combination of pressure control and volume control, and that's your VC+. So in VC+, it's a pressure regulated or an adaptive pressure targeting a volume. Okay, so we're going to still target that 8 mils per kilo, because that's where we're going to start via ARDS-NET and then BRC. Okay, so we're going to stay at that 520. Our I time now, this is a pressure mode. Okay, it's a pressure controlled mode, so we can set I time. What we cannot set is a consistent flow, because it will change. Okay, so let's go to that 0.85 again. Okay, and we can still change our rise time because this is pressure control. We are now going to be really careful and set a high peak as well as a high tidal volume. So here we have set the high tidal volume to be at 650, and since this patient's approximated to be 65 kilos, it's about 10 mils per kilo. So once again, we always have to be safe and make sure that we get safe parameters in here. So here we go again, and now you'll see as it transitioned over. Okay, so it had to do a couple of test breaths, and now look how that pressure drops. Okay, so now we go back into that decelerating flow waveform. Here's our pressure scaler again, and it looks great. Everything's nice and even. Patient's accepting breaths. There's no trigger. So now, as the pulmonary mechanics change, you can see a varying flow. Okay, good. See that difference in flow there? Okay, the patient got a little bit tighter. So now, based on that, our peak pressure can go up, and it is. It's going to rise up a little bit. We're still going to try and get to that consistent tidal volume. Okay, now there was a spontaneous one. We didn't like that because it said high inspired tidal volume. So there, because we have that set tight. So here we go. See, now our flow is changing. Okay, so as I change, and it's just saying high inspiratory tidal volume, I'm going to silence this, and we always want to check our alarms as we adjust anything. So as I said, that's really tight, which is good. We want that. It's right there at 650, saying don't go above 650. We have our peak here at 30, and then we have our minute ventilation. So our total minute ventilation, we're getting about 6.86, so we'll say 7. So we'll put that at 9. Okay, and if that's 7, we'll put that about, or we'll say 6. We'll put that at, we'll be really tight and put it at 4 and 9. And yes, I know I'm probably being more careful than you are at clinical, but can't hurt. Okay, so here we go. Once again, we're going to have now a varying flow pattern. Therefore, we are in a pressure-controlled mode, even though we're getting that consistent tidal volume of 520. Okay, so the next thing I want to show you is SimV. So these are all assist control, and we've gone through 3 things with assist control. We've gone through volume control, pressure control, and then the adaptive pressure. So now we're going to go over here into SimV, and we can still be in pressure control, volume control, or VC+. So we're going to stay in this VC+ because it's kind of the best of both worlds, pressure and volume. We're going to stay at our 8 mils per kilo. Now we're just going to add a little pressure support. Okay, so let's start out nice and low, pressure support of 5. That'll be above our peak level of 5. I'm going to keep All my other parameters the same. Now, another thing that's highlighted here is our expiratory sensitivity, and it says at 25%, and that is going to be on those pressure-supported breaths. It's going to know when to cycle over to exhalation. Okay, so now we're in spontaneous mode. So now, unlike the assist control modes, when we get a spontaneous breath, which it's sensed here, the trigger is flow. So when the ventilator feels 3 liters per minute of flow being taken out of the circuit, it's going to say, hey, the patient's trying to take a breath. So that's good. So rather than having that tidal volume of 520, it's going to get a pressure support. Okay, so it's just going to be when the patient wants to take one, you can see that little blurb there. Okay, it's just giving a little pressure supported breath. And we can watch our tidal volume here. That's the mandatory one. We can look at, we can look at it right here actually to see what our pressure supported breaths are. And you can see that was a spontaneous. We could see that dip, negative dip below the breath itself. Once again, such compliant lungs, the tidal volume is still very appropriate on those assisted breaths, pressure-supported breaths. And you'll see that on the pressure-supported breaths, you'll have a peak around 10 here, because your PEEP is at 5, and your PEEP, as you recall, is your baseline pressure here. And then it's a pressure of 5 centimeters above that. So that's a SimV. Now I want to show you the bilevel mode, because that's what's next. So on bilevel, you are still setting a high pressure and a low pressure, very similar to what you would do on, say, a BiPAP. However, the difference in bilevel is that when we get into the real airway release portion of that, and that's what this is for. So it's called bilevel on this ventilator because it can do both. But when you start going into the inverse ratios, that's when you start talking about that airway release ventilation. So here we're going to keep this P high pretty low, because once again our test lung here is very compliant. So we'll start at a P high of 15. We'll start at a P low. We'll just take that down to 0. So we're not going to spend that much time here. We're going to keep our rate at 12. We can still do a rise time because this is a pressure control only mode. We're only setting pressures. Now the T high, this is what makes this mode different. Okay, so we're going to put the T high to 4 seconds. Okay, so rather than like a 1 second I time, we're going to do a 4 second I time. Okay, so T high, we're going to go up to 4 seconds. Now it's going to say, now wait a minute, these ratios are at a 1-to-1. So I'm going to hit this continue to say, yes, I really do want to do this. Okay, so my T high is going up to 4. There we go. Okay. Now our T low, you can see there, that you have to push these 2 buttons to adjust to see if you want to do the T high or the T low. So now we're in T low. Okay, pressure support. You can still be in assist control or SIMV with bilevel. Okay, so pressure support, because the exhalation valve opens up when the patient wants to take a breath. They can breathe spontaneously. So it's it's inflating, it's getting those the mean airway pressure open, it's increasing the functional residual capacity so that the patient's lungs are expanded, and so there's great surface area so we can have gas exchange. However, they still can breathe they still can breathe spontaneously on the high level and the low level. Okay, so let's check this out. Let's look at our waveforms on bilevel. So you'll see, watch the lungs. And if you look at the waveforms, this is inhalation. Now it's warning us that we're getting high tidal volumes. And once again, we've got our compliant lungs. So I'm going to just go and check the alarms here. Yep, I'm still at, now I went up to 950. So I'm going to really have to get this pressure high down there. So we'll go around 10. Okay, now we're down 800. So if you look here, this is the point where inhalation is happening. So those lungs are just staying open. And now when the patient drops down, so we are at a 4-to-1 I to E ratio. Okay, so once again, it's saying minute ventilation, we're overly ventilating this patient. Yes, I understand. Okay, so you just have to be careful because it's all about the patient's pulmonary mechanics. Okay, so when you're flipping modes like this, you just have to be careful and really make sure that your numbers are staying safe. So we're staying 4 seconds on inhalation, and when we have that drop down, that is what is getting rid of carbon dioxide. Okay, but now watch what can happen if the patient wants to breathe spontaneously. Okay, so they took a spontaneous breath. You'll see that they'll be able to do that, and it's like they're starting at the baseline and at the high level. Okay, so they're just breathing at the high level, which is still their baseline, and then if they want to breathe over at the low level when they're down there, then they can do that as well. So where you would start this patient is, in general, most of the time, if you were starting in bilevel, you would find where on conventional the patient's plateau pressure is, which we did before, and it was about 10. And notice I'm now on a P high of 10. So take where their plateau was before and start their P high at that level. That's a pretty common way to start. And then, of course, monitor your patient. So why you would want to do bilevel or APRV, as I said, it's called different terms on different ventilators. The reason you would do that at the hospital and at the NBRC hospital is if you have a patient that you are maxing out settings on conventional ventilation and you're looking for another way to oxygenate the patient, then you can try this APRV. This is called the open lung strategy. And so it'll hopefully reduce those large pressure swings, those consistent high pressure swings, so that the patient won't get the lung injury that they're used to, that you might get on conventional. Of course, it's controversial. You will most likely see it at some point and utilize it, so please understand how to use it. So once again, look at the patient's plateau pressures on conventional. Go to a 4-to-1 ratio to start. You can do it in SimV or assist control, whatever your hospital's protocol calls for. And then give it a try. Watch your patients. And then you can add a pressure support if you're in SimV. If you're in assist control, of course, you can't add a pressure support. And then, of course, the other thing we can do on here is our spontaneous. So I can flip this over to spontaneous. So if we go to the spontaneous mode and then pressure support, tubing compensation, volume support, or proportional assist ventilation plus, all of these are a spontaneous mode to help your patients in different ways, so that you are setting either in proportional assist, where you're saying, okay, I want you to assist them, say with 30%. So they're doing 70% of the work, the ventilator's doing 30% of the work, or you can just do a good old-fashioned CPAP pressure support, which you probably will do. So of course we'll set our peak to 5. we will set our pressure support to 5 also. And once again, that's about what it's been taking for this very compliant patient. Okay, and so now you'll notice the patient isn't going to be triggered, so I'm going to do the triggering. Okay, so when I did that, they got a nice pressure-supported breath. All of these are going to have that negative deflection beforehand. The tidal volume, they're getting about 9.5 mils per kilo spontaneously. So we could then decrease that pressure support. Now let's see what we get. Okay, 629 is a little better. Okay, 452. So that's a little bit better. That's about 6 mils per kilo. Well, it's about 7. 390 is 6 mils per kilo, and that would be perfect. So we really don't need much. One thing I'm going to do is turn down my sensitivity, because if you noticed, I've done some triggers where it didn't give too much of a breath here. There we go. Okay, it reacted to that a little bit better. Okay. Okay, so it's still staying about 493. So that's about 7 mils per kilo. Not too bad. So I can't really go down any lower. I just have such compliant lungs here. But that's what we would do. So the pressure support, so when you guys are doing a wean, a spontaneous breathing trial, you're going to look at that pressure support is still allowing your patient about 4 to 6 mils per kilo spontaneously. Okay, so the pressure support is helping because of the resistance in the endotracheal tube and all of this dead space with the circuit and whatnot. So it's just giving them a little bit of support, but having them do all the triggering and really working their muscles. So it's a way for you to assess, and then to assess all of the other body parts as well too. So neurologically, the kidneys, the digestive tract, the liver, and of course the heart and the lungs, to see if the patients are healthy enough to come off of mechanical ventilation.